great. If you could see your faces. So good afternoon. I hope everyone had a great weekend. It was too short for me, to be honest. But welcome to the House Health and Government Operations Committee. My name is Jocelyn Peña-Melnick, and this is the Public Health and Minority Health Disparities Subcommittee. And we have a full agenda today, and then we also have bill hearings for the regular committee at 2 o'clock. So we're gonna get through it. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We have 11 bills for today. So we have a lot of work. I want to thank our members for making the time and for coming. I really appreciate you, and for the advocates. As you know, in our committee, we listen to the bills that come up. We try to bring everyone, whether you're for it or against it, and we have a really honest discussion and try to compromise where we can compromise. And when we can, sometimes we just have to do it. But we do give everyone an opportunity to come to our committee. So members, if you could please put your video on, and we'll get started right now. First, we have House Bill 96, and that's Delegate Shetty. And Delegate Shetty and I have been meeting on this bill. Delegate Shetty, I'll give you an opportunity to address the committee, let them know what's on your mind, and then I will let the hospital know what they have committed to. We'll get it on the record, and then I'll speak. Okay, welcome to our committee.
Thank you, Madam Chair, and thank you, colleagues, for allowing me to join the discussion about this bill, HB 96, which would prohibit transplant centers here in Maryland from denying life-saving care to patients purely on the basis of their financial status. I really want to just take a quick moment to, again, just truly thank Chair Peña-Melnick for taking time out of her really busy schedule to speak to all of the stakeholders. I don't take this for granted, and I know that you're doing this because you really care about patients here in Maryland and about this issue, so thank you so much. So by way of quick update for the subcommittee, after many months of calls, texts, emails, meetings with the 2 transplant centers and MHA. Unfortunately, we were unable to reach an agreement on this bill, and we're planning to pursue working together over the interim to hopefully come to a consensus over reasonable and narrow insurance reforms that are needed to enact the core of this legislation, which is the prohibition of the denial of life-saving care to patients. But before I depart, I just need to get a couple of things on the committee's record so that all are aware of what is at stake. So we pulled some data of patients here in Maryland. We have, and specifically those who have been on wait lists at UMS and at Hopkins, or 2 transplant centers. So data we were able to locate for UMS showed that from July 2020 to June 2021, 66 people died while waiting for a kidney. In addition, 21 people died waiting for a liver, 3 died waiting for a lung, and 2 waiting for a heart. At Hopkins, during the same time period, 78 people died while waiting for a kidney, 21 died waiting for a liver, and 1 died waiting for a heart. And so obviously, I think I'm extremely concerned, as I assume most of you are, about those who are waiting for the gift of an organ transplant. However, I'm also extremely worried about what numbers we just don't know. So we don't know how many were offered a gift of a kidney with a perfect match, only to be told by one of the transplant centers here that they can't have it because they can't pay for it. We don't know how many patients were never even informed about the option of transplantation because the hospital assumed that they can't afford it. And worse off, I think, for kidney patients in particular who live about an average of 7 years after beginning dialysis. We don't know how many of those patients were sentenced to essentially death by dialysis because of this information. So these are numbers that keep me up at night. They drive my deep disappointment and why we're here today in this discussion. So I know that the subcommittee committee and the stakeholders recognize that there are really deep inequities here in our healthcare system, but where the crux of the disagreement lies is what that should mean for patients today. So I'm committed to working with the stakeholders to identify common ground, narrow policy solutions to address the concerns of the transplant centers, but I still feel very strongly that we should have passed the bill to address financial status discrimination. And not speaking hyperbolically, as we've seen over the last year alone, patients will continue to die while waiting for an organ transplant. So we are being asked to be okay with that. I am not okay with it, but I will work hard over the interim to bring this bill stronger and better with all of the stakeholders committed to passing it. Just one last thing on the record, I think that is especially important for us to note. We have funded these transplant centers and Maryland has led the way on transplant reform, particularly over the last few years. UNS has received $175 million from the General Assembly's budget, and we've got pending capital funding requests of tens of millions of dollars heading to the transplant center that is turning around and denying care. So I'm excited to work with everybody. Hopefully we are able to find a solution, but I will be bringing this back next year. And I look forward to working with you, Madam Chair, and colleagues. And I thank you for your continued commitment.
Okay, I want to hear from UMS, then from Hopkins.
Thank you, Madam Chair. Thanks, Delegate Shetty. For the record, Kristen Jones-Bryce, University of Maryland Medical System. I'm the Chief External Affairs Officer. I do want to recognize Delegate Shetty's collaboration along the way on this legislation. She has met with us on a number of occasions, and we have reassured her that neither of our programs, the two transplant programs in Maryland, Johns Hopkins and University of Maryland, do not engage in a practice of denying life-saving transplant to people because they lack financial means. I can't verify Delegate Shetty's data, but it's tragic. I think nationwide, thousands of people, I think the last stat I read, 8,000 people die every year waiting for organs on transplant lists. But what I can say is that what those statistics do is they reaffirm the work that our programs do to help transplant patients ready themselves for what is a life-changing surgery. And it doesn't matter what organ we're talking about. There are challenges that stretch from the beginning of a transplant process throughout a patient's life. We have social work teams and advisors and surgeons, obviously, physicians, nutritionists. I mean, the transplant teams stretch far and wide, and also financial advisors on our teams to help people, again, ready themselves for these procedures. I think what Delegate Shetty's bill does is it does speak to the hospital perspective on transplant, but what it doesn't get at, and we've sort of struggled as we've talked about potential amendments on this bill, are all of the expenses that stretch out past the date of someone's surgery. So people wake up from transplant automatically needing anti-rejection drugs that can cost thousands of dollars every month. And those aren't drugs that we supply directly. These are drugs they would obtain through their insurance coverage. And that in and of itself is a huge challenge for many, many people. And I think our programs do a tremendous amount of work trying to help people get ready for that inevitability. And some of the concerns I think we face are, look, if we do this and we say to a patient going forward, we need to get you enrolled in Medicaid, right? You qualify for Medicaid. We need to help you get enrolled in Medicare. So these costs are covered going forward. Is that a moment when we've denied coverage for financial status? I mean, those are the kinds of practical things that happen throughout this process. And we just want to make sure that we are first doing no harm. I think we support the intent of Delegate Shetty's bill, absolutely. Again, we do not engage in this practice in either program, but certainly appreciate the need to do everything we can to support transplant patients both from a healthcare perspective and financially. So, Madam Vice Chair, I thank you for the opportunity to address the committee, and I'll either answer any questions or defer to my colleague from Johns Hopkins.
Okay, John Hopkins, please.
Hi, good afternoon. Elizabeth Lee, the Associate Director for State Affairs from Johns Hopkins. First of all, thank you for this opportunity to be here before the committee. I won't rehash everything that Kristen indicated, but that remains true as well for Johns Hopkins. We certainly support this legislation in concept, but to some of the concerns that Kristen raised, we similarly have the same concerns. However, I thank Delegate Shetty for her patience over the last couple of meetings. She has met with a couple of people from our team, from our transplant team, who work every day to help our patients get the care that they need. I'm likewise proud of the work that they do at those centers. And I thank Vice Chair Penny Melnick as well for her patience and for her meeting with us to allow us to continue to have conversations about this legislation. And we hope during the interim that we can work with Delegate Shetty and the Vice Chair and others to come up with a solution that is works for everyone. Thank you for this opportunity.
Okay. So I think that I wanted to bring it to the committee because I know that Delegate Shetty is very disappointed. Us not moving forward doesn't mean that we're okay with it. Absolutely not. If we had been okay with it, I would not spend the time on the bill and the meetings that we have had, or bring it today. The thing is that we want to, no other states have done this, and it's the first time the bill is introduced, and we want to make sure that it's done right. And they obviously have concerns. We can get it out of the House, probably, but then I know for a fact it won't get out of the Senate. And that's not a good exercise of our time because we want it done right. So I think that what I would like to do is for a letter, as I requested from UMS and Hopkins by the end of this week, that states that you do not, require a certain amount of money in a bank account. I like that in writing, and I like your commitment that you will work in the interim. You will put together a work group of people that will come together to try to find a policy that works in Maryland. I have asked Delegate Shetty to give you suggestions on the membership of that work group, people that should be their experts. And I like her to be part of that work group as well. So I would really appreciate that. And while we're here in subcommittee, is there a member that can work with Delegate Shetty and the hospitals on this in the interim? It's not a bill, but we know sometimes we don't need a bill. We get a lot of stuff done with a letter and with a commitment of our partners. Is there someone in this subcommittee? Delegate Bagnall said that she will work with Delegate Shetty, which is wonderful, and with the hospital UMS and Hopkins, okay? So is everyone in agreement? Wonderful. Yes. Are there any questions from the committee members? All right, seeing none, I expect respectfully the letter by the end of this week. And the letter should contain language stating that there will be a work group where Delegate Shetty and Bagnall will be part of. Delegate Shetty will give you some of the membership for the work group. I thank you for your time and for your willingness to work. And Delegate Shetty, I thank you for your patience. We will get there. Maybe not today, but we'll get there 10 months from now. Okay? Thank you so much. My pleasure. Thank you, Delegate Bagnall, for volunteering, and thank you to UMS and Hopkins for coming, and to the Maryland Hospital Association as well, and Delora. Now we go on to House Bill 293, which is the Behavioral Health Crisis Response Service 988 Trust Fund. Basically, we're here. Erin, can you just tell us what the bill does quickly, and then the advocates will discuss the funding. We're going to hold the bill because we're working on the funding, but we want to have a discussion so when we do bring it to you, to all of us for a vote, we know what we're voting on. And I will allow Delegate Lewis Young, after Erin speaks, to say a few words as well. As we do in this subcommittee, everyone gets a voice. Erin, go ahead.
The bill establishes the 988 Trust Fund to provide reimbursement for costs associated with designating and maintaining 988 as the universal telephone number for a national suicide prevention and mental health crisis hotline, and developing and implementing a statewide initiative for the coordination and delivery of the continuum of behavioral health crisis response services. MDH must designate 988 as the state's behavioral health crisis hotline by July 16th, 2022, in accordance with the Federal National Suicide Hotline Designation Act of 2020. MDH must also administer the trust fund and collaborate with specified entities to promote consistent public messaging of 988 services, and they must also submit a report on specified activities by December 1st of each year. As introduced, the bill requires the governor in fiscal 2024 to include $10 million in the annual budget bill for the trust fund.
Delegate, thank you, Erin, for that description. Delegate Lewis-Young.
Thank you, Madam Chair.
My pleasure.
So, of course, the challenge in this bill has been the funding. And as you all know, a certain level funding request must go to the Speaker. And I received confirmation from the Speaker's office last week that the Speaker is willing to match federal funding up to $4 million. So I've moved ahead and spoken with some of our federal funding resources, in particular, Congressman Trone's office. He is my congressman. He also sits on appropriations. He is writing, if you haven't received it already, a letter of support for this bill. And his office has agreed to assist us in trying to procure that federal funding so that the match requirement will be met.
Thank you, Delegate Lewis-Young. I know this bill is very important to you and very important to the community, and thank you for all your efforts. I now will open it up for the advocates. Would they want to be heard?
Sure. Thank you, Chair Peña-Melnick. Wanted to share just where our funding request came from. We put $10 million into this bill. This is based on a national SAMHSA funded estimate of what Maryland would need to be prepared for the projected increase in call volume that we expect when 988 goes live. 988 is a more easily remembered number, and we expect a national public awareness campaign to accompany the launch that will be directed by the federal government. So we expect a significant increase in call volume. This $10 million came from a national estimate by the administrator that operates the national system that 988 will be built upon. And they looked at both the projected increase in volume for phone, text, and chat, and the expected cost per contact, cost per call, cost per text, cost per chat. They came up with a range of $10 to $17 million, depending on how consolidated our operations were. And so we believe that $10 million is a credible proposal for what is needed to be deposited into this trust fund to ensure that call centers are prepared. What we don't want is people in need in Maryland to call this number and have the phone ring and ring and ring, and then get kicked to a backup system where the person who answers the phone is not familiar with the resources in Maryland, may not be familiar with the local events that are occurring in Maryland. We want Maryland call centers to answer calls made by Marylanders. And so we really want to make sure that our call centers have the staffing and the infrastructure needed to answer any call, text, or chat that comes from a Maryland resident. I know my colleague, coworker at PHSB, Adrian, wanted to share a word or two as well.
Go ahead.
Respectfully, Madam Chair, if you don't mind.
Go ahead, quickly. Yep.
Thank you. Good afternoon, members of the committee. with Behavioral Health System Baltimore. I'm Adrienne Bridenstine. We're also convening the Fund Maryland 988 campaign, which I know many of you have heard of. It is a campaign of nearly 70 members and organizations across the state that support this piece of legislation. And I did just want to mention that the campaign and the advocates do have some concerns with the match language and how that might actually be applied to the federal grant that the state has received to support 988. So I wanted to express that concern in subcommittee as you're considering how we would move forward with this piece of legislation. There could be challenges with including that language. We do recognize that $10 million is a large ask, but we think it's justified and hope that as you guys work through this, you'll consider that as you move forward. Thank you.
So as you know, this came from the Speaker's office, so this is what is going to be done. So we have to make it work. So we'll just wait and see how they work that out, but the committee won't do anything differently than what we have been told because they know what's in the budget and the funding, okay? So we, as long as you know, we're gonna work within those guardrails.
I totally understand.
My pleasure. Does anyone else want to be heard? Okay, great. So we're gonna hold this bill until further notice, and Delegate Lewis-Young, you keep us posted when you want it back in subcommittee. And I know Erin has been in close communication with the Speaker's office so that we can put it back in and vote it out, okay? Thank you for all your efforts, and thank you both for the work you do. You're doing God's work out there, especially during these times, so thank you. We are now going to go on to House Bill 534. 534 is Maryland Medical Assistance Program, self-measure blood pressure monitoring. Now and then I hear that New York accent in myself, you know that? Erin, will you tell us what it does?
This bill requires Medicaid beginning January 1st, 2023 to provide coverage for self-measured blood pressure monitoring for all Medicaid recipients diagnosed with uncontrolled high blood pressure. The coverage must include the provision of validated home blood pressure monitors and reimbursement of healthcare provider and other staff time used for patient training, transmission of blood pressure data, interpretation of blood pressure readings and reporting, and delivery of co-interventions.
I think that is Delegate Banjari. Is he here?
He was invited, but I'm not.
Okay, I think Eric Galley's here to speak on this bill, correct, Eric? You must unmute yourself, Eric, so we can hear you.
Hi, Madam Chair.
Okay, wonderful. You want to be heard on this bill?
Yeah, we're very hopeful. We know that this bill would save a lot of lives and prevent a lot of suffering. And it happens in doctor offices every day where insurance pays for it. And it really is the best medicine and the best medical practice. A lot of us have parents or aunts or uncles who are doing this. The doctor's office calls them once a week or every 2 weeks and gets their measurements and uses that to titrate medicine up and down. And in some cases, they find out, we had a doctor talk about, in some cases, they find out that the person gets very nervous in the doctor's office, but when they go home and a couple days later take their blood pressure, they find that it's normal. There's all kinds of things that happen when we track the blood pressure of these folks who have high blood pressure, and we would urge you to support the bill.
Are there any questions for Eric or for Erin and I on this bill? I know there is a fiscal no, we're working on that with leadership, but I'd like to vote on the bill. Are there any questions or concerns with this bill? Okay, seeing none, may I have a motion on the bill, please?
Move the bill.
May I have a second? It's been moved in second. Any concerns? All those in favor say aye. Any opposition to the amendments? Seeing none on the bill as amended, may I have a motion?
Delegate Payne-Melnick, there's no amendments.
Oh, I'm sorry. You know what? Thank you. It's a very simple bill. May I have a motion on the bill?
So moved.
Is moving second. Okay. Delegate Shalega.
Thank you. Can you tell us what the fiscal note is and what the fiscal note solution is and what the Speaker's office has said about it?
Yep. Erin?
There is a $560,000 general fund fiscal note in 2023. That increases up to 1.1 million in 2024. What this committee does is after bills over $300,000 pass out of subcommittee, there's an email sent to Chairman McIntosh and Speaker's staff requesting approval of anything over $300,000. So that would be the next step in terms of the fiscal note.
And what are the out years? It ramps up pretty quickly to over $1 million. Is it $1 million every year after that? You're muted.
It stabilizes at 1.128 through fiscal year 2027, which as far as our fiscal notes go, 5 fiscal years.
Okay, all right. Thank you.
My pleasure. Delegate Chisholm.
Thank you, Madam Chair. And I was looking at the fiscal note as well, and it says an estimated 22,568 Medicaid participants may need blood pressure monitoring due to diagnosis. It said half of these individuals, 11,284, seek self-measured blood pressure monitoring. Is the fiscal note, if you know, Aaron, based off of the 11,284 or off of the total 22,000?
It's based off the 11,000.
Okay. All right. That's the question I had. Thank you.
Thank you for the question, Delegate Chisholm. I appreciate it. Are there any other questions from the committee? Any concerns? Okay. All right, and we were voting on the bill. Are there anyone object to the bill? Delegate Chisholm, your hand is up. All right, I don't see any objection to the bill, so the bill passes unanimous, and we will deal with a fiscal note. Thank you, everyone.
Thank you, Madam Chair.
My pleasure. Next, we have House Bill 570, and that is the pesticide, mosquito control product, and PFAS chemicals. Erin, can you tell us what the bill does?
The bill generally prohibits the state, a local government, or a certified applicator from using a mosquito control product that contains PFAS chemicals. Also, beginning December 31st, 2022, the state, a local government, or certified applicator may not use a mosquito control product unless the Maryland Department of Agriculture has certified that the product does not contain PFAS chemicals. The bill also requires a pesticide distributor, when registering a pesticide used to control mosquitoes, to submit an affidavit stating whether the pesticide has ever been stored, distributed, or packaged in a specified container or contains certain PFAS chemicals. There is an amendment on page 1 of your packet that provides that nothing in the bill would require the Department of Agriculture to test pesticides for PFAS.
Okay, so the amendment gets rid of the testing, correct?
Correct.
Okay. Eric, I know you want to be heard. Go ahead, and then I will open it up for the committee members.
Well, we hope that the amendment gets us to where we thought we already were, which is that we are not making MDA or any government entity in Maryland to test. The industry, the chemical company pays for the testing, gets it tested, and then sends an affidavit to the MDA that says we passed or we failed, and it gets considered in their certification. So there would be no requirement on a government entity to do anything except collect paperwork.
Are there any questions? One second. All right. There's Lindsay Thompson.
Good afternoon, Madam Chair. Lindsay Thompson here today on behalf of the Delaware Maryland Agribusiness Association. We do still have some concerns with the bill. I am happy to hear that the testing requirement for the department has been removed, given the fiscal note that was associated with that. We do still have concerns given the ongoing rulemaking at EPA, as well as conflicts with the definition of PFAS in the bill and the lack of a federal definition of PFAS as it relates to pesticides and FIFRA regulated products, that the bill would be difficult for the registrants of these pesticides, not distributors, but the registrants of these pesticides to comply with. And if they are unable to comply, then they would be unable to provide that affidavit and could potentially lead to a lack of availability of pesticide products to do mosquito control in the state, and potential public health impacts that would go along with that. I have here today Karen Reardon from RISE, who is really the PFAS expert as it comes to pesticides. And so if there was any clarifications on anything that I said, she would be able to provide more technical information.
Thank you. I know that MDA is also here. MDA, who's representing MDA?
I guess it's me, Madam Chairman.
Wonderful. Well, we would like to hear from you.
I'm Tom Phillips. I'm the state chemist with the Maryland Department of Agriculture. My program registers 6 commodities, which one of those is pesticide products. Our biggest concern is the self-policing of the industry. I've personally not seen any industry that's really good at self-policing. We would have to end up doing random sampling and random analysis just to make sure that this bill is being followed by my registrants. The other thing is right now there's no official methods and there's no EPA certified laboratories for this type of product. Each pesticide product formulation is going to be different from each manufacturer. They don't behave the same. And that's personally, that's my biggest concern, is to make sure that they are going to follow the letter of the law and do this. But thank you for your time.
Thank you. I know that Delegate Kaiser has a question, and then I'll let Mr. Ghali go. Delegate Kaiser, the floor is yours.
Thank you, Madam Vice Chair.
My pleasure.
When I had my question up earlier, my hand up earlier, as I think Delegate Chisholm did, I think Mr. Ghali answered our question of the certification. But on my question for Mr. Phillips, when you described that there wouldn't be a process for random sampling or going back and assuring that people are doing this, it seems to me that as the bill is amended, it's kind of a first step. And we know that when we pass certain laws, just the putting it on the books scares enough people into compliance. So it seems like that's a good first step, and maybe we would be coming back in a couple of years to do better, to figure out a process. So, so that's just my response to that one concern you had, though I do appreciate the other concerns that you brought up.
Mr.
Thank you, Madam
Ghali,
Chair.
my pleasure. Oh, actually, Delegate Chisholm, did you have a question? And I apologize if I didn't see you. No? Okay. I just want to make sure.
It was answered by Mr. Ghali.
Okay, thank you. Thank you for your
Thank you, Madam
flexibility.
Chair.
My pleasure. Mr. Ghali.
Well, I should probably quit while I'm ahead, but I did want to note that there was another concern that came up about would there be products? And we looked at what the testing that Massachusetts did and the testing that MDA did, and that is the testing that we are recommending, is that 6 of the 14 products that were tested in Massachusetts passed with flying colors, and that 2 of the most used products, Permacease, and there's another one, I can't move my screen. Anyway, 2 of the very most used products also passed with flying colors. So this idea that there won't be products on the market isn't true.
Okay. Delegate Shalega.
Thank you, Madam Chair.
My
Lindsay,
pleasure.
You said you have brought on to our subcommittee meeting an expert on PFAS nationally.
Yes, ma'am. So Karen Reardon with RISE, which is the Specialty Pesticide Industry Association, is kind of our go-to on PFAS issue because, quite frankly, it's really complicated. And so we rely on her for technical expertise.
That's great. We had a PFAS bill in last week, and we have learned that it is complicated. So Karen, please weigh in, tell us more about PFAS, tell us about the challenges with implementing a bill like this from a scientific standpoint.
Thank you, Delegate and Madam Chair. This is a very complex issue, and when we're looking at the mosquito control products available in Maryland, one, we want to protect people from vector-borne disease, but two, to understand in this matter of PFAS and mosquito control products, this was a matter of something with the container. So it is not a matter of the formulated pesticide product. And as was noted by MDA, your chemist, we do not have testing methods. This is a new and emerging area. EPA is still in its investigative mode. It is looking at what is occurring with the containers. That work is being done at Fort Meade, Maryland, right here in our state. Those results are forthcoming from EPA sometime over March and April of this year. So we will have a better sense of what was going on in those containers that held those mosquito control products. I would reiterate, upon the development of a validated method for oily formulations, all the products came clean. They were free and clear. So I would be concerned in this case, we need to be certain about what we're looking at. People of Maryland are protected. PFAS are not intentionally added to pesticide products. The matter of fluorinated chemistry is very complicated. The matter of fluorinated containers, HDPE containers, also is a specialized process. Not all pesticides are in such containers. So I share these details to say it's complex. In the matter of mosquito control products, EPA's validated method used by the states did show that there were no detections of PFAS substances once a validated method was available for certain types of formulations. EPA is developing in partnership with states additional methods, but they don't expect to find materials that would be detectable in the environment or that are creating harmful exposure.
So Karen, I think what you're saying is the products used to treat for mosquitoes do not contain PFAS.
No.
But the containers that they're in may or may not. So if we pass this bill and we ask pest control companies to test their products, of course they're going to test fine, and it's not going to get to the problem because the problem's with the container, not the product. Is that what you said?
Potentially, yes.
Potentially. And you also said that EPA is in the midst of writing some regs on this, and they're looking at it right here in Maryland, and that we may have some answers on this maybe in April or May on because this is obviously PFAS, we're all concerned about our drinking water and our air and the health of our environment. You know, that's a universally understood concern. So the federal government is looking at doing something in a couple months. That's what you said?
With respect to the pesticide containers, yes. They have been working for the past year and a half out at their specialized lab at Fort Meade, and in conjunction with the sample submitted to MDA. That report is anticipated in the coming weeks. So we're anticipating by April, and they will have a sense of what was occurring with those containers and those materials to create those low levels of detection.
Okay, great. Thank you, Karen. My final question would be for the bill sponsor for adjudication. So if a person believes that a pesticide company is using something that has PFAS. So you could see the problem that the product is tested, it's fine, they submit the documentation. There's some unintended, unknown, unintentional something in the container, and a person challenges that report. What is the adjudication process for the pesticide company and the person challenging?
Mr. Galley, will you please address Delegate Shalega's questions, please?
Yes, well, first of all, I want to say we've presented the testimony of a bunch of well-renowned scientists who say that some of these chemicals do contain PFAS, mostly as inert chemicals, but they have found, and in fact, the Graham Peasley document talks about a lengthy history of finding PFAS in the chemicals themselves. So that's why if you send the sample and it hasn't touched the at that point, it hasn't touched the container, it wouldn't be in there. So if these folks send their sample to be tested and there aren't PFAS in the product, they won't get flagged. They'll be okay.
But you didn't answer my adjudication question. So you've left you've left ag out. I don't understand how someone would challenge the ruling on that, or how a company that's being challenged would where would they go defend? Where would the due process go?
I would think the due process is that they're sending in they're conducting the test and they're sending the test in. I don't know.
Yeah, but when it's challenged, I don't see anywhere in here for a challenge of those answers. You haven't provided a pathway for challenging, or
I don't know how you challenge a pass-fail situation. It's a pass-fail test.
But again, you just heard from Karen that it may pass, but then if there's a problem with the container, a person may say, that's wrong, it failed.
Well, this bill says that if you pass the test, you're good. You get certified.
Okay, thank you, Eric. Madam Chair, I have concerns with when we do things like this and we don't have due process laid out. We leave, both the challenger and the defender in some kind of purgatory, and I'm not sure that's fair.
Thank you, Delegate Shalega. Delegate Chisholm, you have a question?
Thank you, Madam Chair. And I want to follow up on what Mr. Phillips said. And we're asking for an affidavit to be sent in, not into a court of law. So it's just a piece of paper. It's self-policing. We'd like to think everybody's honorable. And I do believe you would get every affidavit saying that there's no PFAS. I think what we have here is we're going after, let's say, styrofoam cups, and we're going to now prohibit Coca-Cola because Coca-Cola could have been carried in that styrofoam cup. We're going after the wrong product. I mean, if the EPA is now looking at the containers, then that's step one. There might be trace PFAS in some of these chemicals because of the container. But obviously we're all admitting here, it's not really in the PFAS. Maybe there's trace amounts like Mr. Galley said, but not enough that it's disturbing the environment. There's a negative effect. It's just simply because of the container. And if they make changes to the container, that's step one. And then if we find that there's a greater deal of PFAS, then you can start to address that. But this is done way out of order. And it's just my opinion, Madam Chair, just the way that I'm looking at this, because you're going to get all these affidavits saying there's no PFAS in here because there's self-policing, plus to their knowledge, there isn't, unless it sat in the container for an extended period of time to the point where it did put some trace PFAS in there.
Thank you, Dr. Chisholm.
Thank you, Madam Chair.
My pleasure. We have Drew Smith-Perkins.
Sorry, thank you. Also representing Smart on Pesticides. I did just want to point out that the manufacturer isn't self-testing, and we can understand how that would be a concern. They're actually sending it to one of these labs like Fort Meade that's already doing these tests. Fort Meade is doing the test, or another EPA-approved lab And they're the ones that are providing the certificate. So I think that should give us all a bunch of more certainty about the effectiveness of the test. And then if it's a container or if it's in one of the inner ingredients of with PFAS contaminating, that should be a concern either way. We shouldn't be inadvertently spraying our communities with this, as this committee knows all too well, a very serious situation. We agree this is just a step, and it at least helps the communities now reduce their risk from getting sprayed by pesticide by using sound existing testing, making sure we're not inadvertently hurting our communities. Thank you, Madam Vice Chair.
Thank you. Ms. Lindsay Thompson.
Thank you. I just wanted to clarify and circle back to a question that Delegate Szeliga had pointed out regarding the testing and essentially what is acceptable testing, right? So really the precipitating event for this bill was some independent testing of Maryland pesticide mosquito control products that indicated the presence of PFAS that then when retested by the Department of Agriculture and EPA with verified testing methodology for these specific types of products, in fact, did not find the presence of PFAS, right? So even though we have a validated testing methodology now from EPA, we still do not have certified labs or testing facilities, right? So questions of, the verified method, what are acceptable labs, are still definitely lying out there. And when it comes to pesticide products, the US EPA FIFRA regulatory process for registration requires disclosure of the ingredients in that pesticide, including active and inert ingredients. And so, they are not knowingly included in the pesticide formulations themselves, and that is information that EPA has. And so, we do have some concerns with if there is a challenge to that, it's not laid out in the bill as to what are acceptable testing methodologies and what are acceptable labs to be testing these samples.
Okay. Any other questions or concerns from the committee? Okay. Seeing none, I'm going to be holding this bill, Mr. Galley. I am going to advise you, like the other PFAF bill, where we directed the sponsor of the bill to work with a different industry in the department, especially on the definition and testing, to work with the MDA on it and see if you can come to some agreement, okay? What the definition is and the testing and the due process as well. It's the same sort of charge that I gave Delegate Love on the other bill, and she did it beautifully, okay?
Thank you very much.
My pleasure.
Appreciate it.
My pleasure.
Yeah.
Thank you for your time today, and thank you for the experts. We appreciate it. Next, we have House Bill 578, which is the Maryland Medical Assistance Program's prior authorization for drug products to treat an opioid use disorder prohibition. And if you notice, we had this bill a couple of times on the agenda. I removed it and I instructed, as I just did, the sponsor and advocates to work on it with the Department of Health, which is exactly what they did. So I will now go to, actually, why don't we have just a free description, since we just have it, some people may have forgotten. Erin, just tell us quickly what the bill does, and then Delegate Kaiser, if you can address us with the amendment, please. Thank you, Erin.
The bill as introduced would have prohibited MDH from putting prior authorization requirements on drugs to treat opioid use disorder. There's an amendment on page 2 that reflects an agreement that was made between MDH and the stakeholders. And this requires the department to conduct an analysis of prescribing patterns to identify prescribers who regularly prescribe non-preferred medications when used for treatment of an opioid use disorder and contain methadone, buprenorphine, or naltrexone, and conduct outreach with educational materials regarding the consumer benefit to prescribing preferred drugs, monitor ongoing prescribing behavior, report on any change in prescribing behavior over time, and identify any barriers to members' abilities to obtain medication in a timely manner. The department is required to submit a report with the initial analysis of prescribing behavior to establish a baseline for future measurement by October 1st, 2022. And then the department is required to annually submit a report with its findings and recommendations each year, beginning in October 1st, 2023.
And just to remind the committee respectfully, we already do this for commercial, for private insurers. People on Medicaid are our poor community in Maryland. And we know that the opioid, addiction is a crisis and people are dying, and putting barriers, it's really oftentimes waiting a day or two between life and death. I say that this is why I'm spending a lot of time from the committee on this bill to try to find a compromise. So Delegate Kaiser, tell us what you have been able to do, if anything.
Well, I think it was really already described by council, but I will back it up a little bit for you, Madam Vice Chair. We were trying to find all the different ways we went through many variations of trying to figure out how to get these drugs in the hand of low-income Marylanders who are using Medicaid. And everything we tried didn't seem to work in terms of the rebates that are already happening in the arrangements that MDH has with those companies. So what came out at the end was what was suggested by Ms. Roddy at some point was to say, we already send out letters to all the prescribers across the state to say what's on the preferred drug list. And because they know who's not using the drugs on that list, that they can do a follow-up. And so we talked further about what that might look like. And one thing we know is that they could potentially do it without us telling them to, but we also know that a lot of times we know that that might be the intention, but maybe that could change later. And we all know that it could be under, certainly under new leadership by next year in some places. So we thought it was necessary to put this into law, to have 2 extra letters going out to those who aren't prescribing off the preferred drug list. And again, it can be targeted and then to be able to come back. And when we talk about reports, I hate long reports. I would want the report to be, at this time of the year, we identified 800 of our many thousands of prescribers not taking off the PDL. And after we sent 2 follow-up letters, that changed the behavior of these many hundreds of them. And then, hopefully over time that gets even better. The cost of such mailings twice is very minimal. I can't imagine more than even 4 figures, but we were also assured by MDH that by getting more people to use the drugs off the preferred drug list, that in fact our rebates would increase. So really more money would be coming back to the state. So it's a net positive, though that's not the reason we're doing it, but just for anyone who may have any cost concerns. But Ms. Seacott worked really closely with Tricia Roddy and with Athos, and I know that we have Heather Scheck here from MDH, and I think she's been nodding a lot. So hopefully others have noticed that as well.
If I may, thank you, Delegate Kaiser, for your time on working on this bill. If I may, I would like NCCA to please address us, and then I'm going to allow Heather to address us as well. Ms. Scheck, go ahead, Ann.
Thank you very much, Madam Chair. I want to thank thank the sponsor, Delegate Kaiser, and thank there were a handful of legislators who gave some extra time to this, Delegate Hill, Delegate Johnson, Delegate Bagnall. Really do appreciate everybody's efforts in this. And the department gave us, I think, a very decent amount of time as well. And in the spirit of compromise, it's not all that we wanted, but we think that doing that outreach, doing some public education, doing some analysis, and identifying where other barriers might exist, I think is well worth this effort. So we thank everybody for their investment and your concern for the topic.
Ms. Scheck.
Thank you.
Welcome to our committee.
Thank you. Thank you so much for having me. I'm just going to echo, you know, the delegate and Ann both. Oh, well, both Anns. They really accurately described all the work that went into this. And so, you know, a huge thank you to them. And as Ms. Seacott said, you know, it's a compromise. And I think there's going to be some really good information that comes out of it. And at the end of the day, we'll be able to get these prescriptions into the hands of the people that need them more quickly. So I think we're going to get some very good information from this. So thank you to everyone, all the hard work that went into this, our late night meetings. So very much appreciated.
And I want to thank you, Heather, and the Department of Health for making yourself available. I have to tell you, I do appreciate when you come to the committee, because this is public health, right? And oftentimes our fiscal notes are high. And when we don't have your voice, we end up doing it, right? And we get some beef because of the fiscal note, but we have to do it because we know that it's the right policy. But when we work together, like you just did, you know, we tend to compromise, right? And your voice is important. So I just want to say thank you, okay?
Thank you
so much. And I always welcome you here, all right?
Thank you.
And you have my cell phone, so feel free to call it as well. So are there any questions for Heather or Delegate Kaiser or Ms. Seacott? Delegate Riley.
Thank you, Madam Chair. So did they, MDH, just to clarify, did they speak about the current bill as written and they're okay with it, or is there an amendment to the bill?
The amendment is going to take place of the bill, Delegate.
Okay,
So
I just see the amendment, okay.
No, it's okay. It's going
It's on
to
handwritten page 2 of your packet.
Gotcha, okay, thank you very much.
And it's a good question, though. I appreciate it because it will come up. So the amendment will take place, the place of the bill, and they compromise on that language. So with that, the department is supporting.
Okay, thank you.
My pleasure, Delegate. Good question. Any other questions? Okay, wonderful. So may I have a motion on the bill as amended?
Oh, well, move the amendment or
second?
Yes. Okay, on the amendment, any concerns? All those in favor say aye.
Aye.
Any opposed? Delegate Riley, is your hand up for a? Okay.
Sorry.
I do it all the time. It's okay. So, okay, it's unanimous on the bill as amended. May I have a motion, please?
So moved.
Motion to
It's
move
been
the
moved
bill
and
amended.
moved in second. Any concerns or questions? Seeing none, all those in favor say aye. Any opposed? The bill passes unanimous. Thank you so much for working on this. I really appreciate you. So now we have House Bill 588, Local Health Departments and Community Action Agencies, Feminine Hygiene Products. And for the committee, there's an amendment. If you have not received it, because that's important for this bill, please let us know. But Erin did send it, and she'll describe the bill now and the amendment as well. Go ahead.
This amendment came out like right before subcommittee. So I did send it around noon to your emails. If you look on page 4 of the amendment, this is the new language of the bill that states that during fiscal years 2024, 2025, and 2026, the Southern Maryland Tri-County Community Action Committee, United Communities Against Poverty, and Community Assistance Network, in collaboration with the appropriate local health department, will make available feminine hygiene products in an amount sufficient to meet the needs of the woman obtaining the products. These 3 agencies may not require payment for the feminine hygiene products made available. And in fiscal years 2024, 2025, and 2026, the governor is required to include in the annual budget bill funding in an amount estimated to be sufficient for providing the products. On or before December 1st, 2026, the department is required to report to the General Assembly on the implementation of the bill. The bill sunsets in 5 years.
Thank you so much. Delegate Bagnell.
Thank you, Madam Chair. This amended language came out of multiple conversations with MCAP, the Maryland Coalition of Action. Program. So it's the community action agencies, because this is the first time that anyone has done this. There is no other state precedent. So we crafted this language carefully to make sure that the community action agencies wouldn't wouldn't inadvertently have to fund these products. We also worked with the local health departments so that they were removed from the administrative burden, but would still be working in collaboration. And as I mentioned in the previous subcommittee, we are piloting this, but the reason it's written as it is because using the word pilot and using the word grant change where it is in statute. It changes how you implement it. So by the nature of defining the years and defining the agencies that will be working on this, we have limited the scope of the bill without inadvertently moving it into another part of the statute. And I believe that we have our health department and our community action agencies on this call. Oh, actually, I don't see.
Do I have the health department? Did Heather leave? Okay.
I'm still here.
Okay, Heather, are you supporting this?
Yeah, we worked pretty closely with Delegate Bagnall to work on these amendments, and we've committed to helping the community action agencies in the interim so that they have a seat at the table as we develop the processes.
Beautiful. Are there any questions from the committee for Ms. Check? And we know that the Department of Health is supporting it. We know that it's really limited to 5 years, so it's a pilot, and that they got consensus. And if you look at the interlineated copy, almost all the bill is gone with the exception of page 4. Any questions from the committee? All right, on the amendments, may I have a motion, please?
Move the amendment.
Second. It's been moved in second. Any questions and concerns on the amendment that have been agreed upon by the Department of Health? Seeing none, all those in favor say aye. Any opposed? All right, on the bill as amended, may I have a motion, please?
Move the bill as amended.
Second. It's been moved in second. Any questions? Seeing none, all those in favor say aye.
Aye.
Any opposition? The bill passes unanimous. Thank you so much, Ms. Check and Ms. Bagnall, for working on this. We really appreciate it, okay? So next we have House Bill 669, and it's Delegate Lehman, and we're not going to be voting on the bill today, but she will give us an update where this is, okay? Ms. Delegate Lehman, actually, I would like, and it's just out of habit, if Erin would just tell us quickly what the bill does, and then you can tell us where it is. Erin.
So the bill as introduced would have required the Office of the Chief Medical Examiner in coordination with the Behavioral Health Administration to establish a grief counseling services program. The bill would require the governor to include appropriation in the annual budget bill for the program and authorizes the use of funds from the opioid restitution fund for the program. Since that time, I know Delegate, the sponsor did offer amendments at the bill hearing and has been working on the bill. So she's here today to kind of discuss the process she's gone through on working on this bill.
And thank you, Erin, for helping her. Delegate Lehman, welcome to our subcommittee.
Thank you, Madam Chair. It is a pleasure to be here. This is a subcommittee of my second favorite committee in the House of Delegates, behind, of course, ENT. It really is a pleasure to work with this group. I see a lot of friends in this room and got a lot of support following the hearing on HB. I think you said 669, Madam Chair. It's 699.
Yes.
And as Ms. Hopwood said, it would provide within the Office of the Chief Medical Examiner grief counseling and support services to those who have suffered what is called traumatic loss, meaning those who have lost loved ones to either suicide or overdose. What happened just after the February 16th hearing on the bill is that the head of the Office of the Chief Medical Examiner resigned. And now I think more than ever, it was already the case, but the focus has really become sort of singular in working out the many challenges in that office, hiring pathologists, catching up on the backlog on autopsies. I think there is definitely support for an understanding of the need for the program, because it would also provide services to employees of OCME. So I have now shifted a little bit to a work group and am putting together, I have language around a work group, its composition, what it would be charged with. It would have a reporting date of November 1st. And I am working with the University of Maryland School of Public Health. I have someone here. If you allowed her to comment briefly, Madam Chair, I think it would be useful. There are still some details to be worked out, which is why I asked just for a discussion, a brief discussion today. But Erin McClure is from the School of Public Health, and she recently had a really powerful sort of experience with traumatic loss. May she be allowed to say just a few words?
Sure. Good afternoon, ma'am. Good afternoon.
Good afternoon. Thank you for allowing me to join. I want to just first name that when we received this bill, we were absolutely behind support of this. We see that there is definitely a need for this. We've seen this in our own institution at the university, and I think we'd say this even system-wide, an increase in suicidality and also in attempts. And I know that this is a daily concern that our Dean of Students and many others on our campus are addressing. So in particular, when talking with Delegate Lehman about this, I shared that just about 3 weeks ago, on February 11th, I received a call during a meeting from a colleague of mine who her son had overdosed, and he had overdosed at home. He had just moved back home to be with her to try to get help and care and to get back on track. And so in that moment, she was in shock and not really knowing what to do or who to reach out to. Her husband was home with her, but other than that, she didn't have anyone else. And I said, I'll come there, I'll be with you. So in the course of being there with her, as all of this was transpiring, when I got there, the police had just arrived, the medical examiner had not yet arrived, and the support from the medical examiner's office had not yet arrived. So I was able to witness firsthand what happened during that process. And I actually had shared that originally when the medical examiner arrived, I was feeling frustrated. Like, why is the medical examiner not going straight upstairs and doing something with the body and getting this done and getting this out there? And through the course of this happening, I realized how much care the medical examiner and the medical examiner's team were providing to my colleague. That really was around behavioral health. That was really around an intervention of care, ensuring that she was not feeling responsible, ensuring that she received love, that she received care, and that her son would be cared for throughout the process. So I very much witnessed firsthand the importance of this. And then the other thing that I was very aware of is it's a traumatic experience for the medical examiner and for their team. I could see, the distress for them as they're trying to show care and they're witnessing this grief, this extreme grief that is happening in that moment. And so I just wanted to be able to share with you today where I just experienced firsthand why this is so important. But I mean, we know this in public health, and we've seen this even in our own institution.
Thank you so much, Erin. And so, Madam Chair, I am looking for just a little bit more time to continue working with Erin and her colleagues on finalizing the language around this work group, again, with the reporting deadline of November 1. And also the bill would still amend the allowable uses of the opioid restitution fund to include grief support for those who suffer traumatic loss as like whatever number it is on the list, it's added. I think Ms. Hopwood drafted or helped work on that language. It would be, item number 13, 14, 15 of allowable expenses under that fund.
All right, so why don't we hold the bill, and then that gives you time to work it. As you know, we have crossover next week, but we'll probably be voting more than we were up to this point. So let Erin know when you're ready to have us put it back in subcommittee. We'll do so, okay? Before you do that, are there any questions for Delegate Lehman? She's in front of us right now so she's not surprised next time we put it in committee. Any questions for her? Seeing none from the committee, thank you so much for your time and all your efforts and Ms. McClure, we really appreciate you working with Delegate Lehman, okay?
Thank you so much.
Thank you. Have a wonderful day. Thank you, Delegate Lehman. Now we have House Bill 786, Health Records and Reporting of Overdoses, Limitations of Use in Criminal Investigation or Prosecution. Erin, will you tell us what the bill does, please?
There's a reprint of the bill on pages 3 through 5 of your packet. It reflects amendments that were offered by the bill sponsor at the bill hearing. The bill prohibits overdose information reported by an emergency medical services provider or by the Maryland Institute for Emergency Medical Services Systems from being obtained from an overdose patient's medical record as part of a criminal investigation or prosecution.
Okay. Are there any questions? Is there anyone on this bill that would like to be heard before I open it up for question? Any advocates on this bill here? I don't see any. Okay, Natasha Mehu. And then Nsikak.
Hey, good afternoon, Vice Chair Peña-Melnick. Natasha May here on behalf of the Baltimore City Administration. And so we are here in support of this bill. It is our administration's one of our priority bills. I do know a question was raised during the hearing of the bill in regards to why we were seeking to close this loophole and why we were finding or how investigators were trying to access these records. And so I did want to provide some clarity to the subcommittee, and I'll also be sending this over very shortly over to the committee as well as a formal response. But essentially, we haven't found that they've actually been successful yet in getting these medical records, but they have been really going to our EMS providers and pushing them, saying that they have the right to obtain these medical records through the use of warrants and subpoenas. And as our EMS and administration believes, the law as it existed had prohibited attaining that information directly from the EMS providers. Because there's this ambiguity where investigators feel that the law only says that you can't obtain this these medical records and information from the mapping system itself, as opposed to the EMS providers. They're just being put in this position where at this point, they're saying that they're not going to share this information because the law doesn't allow it, but they're being pushed in directions that say the law intends otherwise. So we see this bill as clearing up that loophole. And that's why we did have that amendment language that stated that it was for the medical records itself, because we believe that no one should be able to exploit a loophole and gain access to that information.
Okay, so this basically is to close the loophole so that the medical record cannot be pursued in a criminal investigation, correct?
Correct, that they cannot go to the EMS providers and get that information.
Okay, because then the person doesn't come for treatment.
Exactly.
Right, that's right. And we have been doing so much in this committee to encourage people to get treatment as well. So NCCAC, would you like to be heard?
Just very quickly, when we all supported, when NCADD supported this bill, when it passed in 2018, there is that, it's very clear intent, the language in the bill about the information not being used in pursuit of a criminal investigation. And without that, NCADD would not have supported this kind of data reporting. So the fact that a loophole's been discovered, we strongly encourage efforts to close that loophole. And you are exactly right, Madam Chair. It's about making sure people aren't scared to seek help.
Yeah. Are there any questions on this bill? I remember this original bill very well. Delegate Hill, then Delegate Johnson.
Thank you. So thanks for the explanation. I think I'm the one that raised the question. And I don't have any problem supporting the bill. I don't think there is a loophole. The AMTs are, completely correct. that they are not allowed to share medical records with anyone without a subpoena, and that's really doesn't go through them. So if it gives you comfort to close a loophole that I don't think exists, that's fine. And I would say, because I think the language is pretty clear also, and I would also say that I don't think that's going to stop the police from asking for those records. But if it gives EMTs more security that they can say no, that's fine. I don't think it's going to change much, but thank you.
Delegate Johnson.
Thank you, Madam Chair. And thanks for the witnesses trying to explain this bill again, because I have to agree with Delegate Hill. I don't see a loophole. So I'm wondering, is it more of an issue of educating the EMS that they are not to give out information on medical records without a warrant or subpoena, rather than closing a loophole that I don't see really exists?
So this would be even if they have the warrant or subpoena, because it's not supposed to be used as part of a criminal investigation at all. And so they're not approaching the mapping app to get that via warrant or subpoena, but they're going to the EMS providers and asking for it. And that's where the EMS providers are in this position where they're saying, the law says we can't, but they're being pushed that in the position where they're being told, well, I'll get a warrant subpoena and we can, even though that's still for a criminal investigation, which the law, as originally drafted and intended, was supposed to prohibit. So we do think it just tries to make sure that there are no gaps in that understanding.
Well, I'm still a little unclear, because it's already against the law for the EMS to give out that information. So I'm sure not really clear on them still going to the EMS asking for this information. It's clearly against the law already for the EMS to give them that information. So I'm still a little confused about this bill. Thank you, Madam Chair.
Okay. And would you like to address that?
The only thing I would add to what Ms. Mayhew said is just that, I think because there's ambiguity, I can sit here and say, yeah, it sounds like you're right. There's not a loophole, but there's clearly some ambiguity that law enforcement sees with the existing law. And if this gives EMS folks the ability to, push back, if it gives the city, city lawyers the ability to clarify with the police department that this shouldn't be happening, making sure obviously that this applies statewide, then I think it's probably worth going ahead, moving forward with the bill.
Delegate Shalega.
Thank you, Madam Chair. And Ms. Mayhew, I'm sorry my battery died, so I missed part of what you said, which is the challenge with meeting virtually. So did you say you have a certain number of cases, or what is the evidence that this is going on? And you said, did I hear you say there have not been any EMS that have given this info because they know it's a HIPAA violation?
So to our knowledge, that the information hasn't actually been, they haven't been successful in obtaining it, but our EMS is being put in a position where they're being told that they should be able to give this information as they're pushing back against it. And the arguments being used are that it's prohibited to get the information from the mapping database, but that the EMS with a warrant or a subpoena, then law enforcement or prosecutors should be able to get it from EMS. And that's not our understanding. And that's the ambiguity there, where we want to have that firm clarity in the law that investigators cannot pull this information either directly from the mapping app or from the EMS providers' medical records of the patient.
Right, but if it's already illegal, why don't you just work with the chief of police, and why don't you just work with the police and say, look, send a letter, have the mayor send a letter and say, this is illegal. Don't, I'm a little confused why we need a bill to do this and why we can't just, work cooperatively and say, you're police, follow the law. You can't violate HIPAA. I'm with Delegate Johnson. I don't think we need this. I think that you should be working with the police to make sure that they feel, you're being heard, the EMS is being heard, and I'm certain they would follow the law.
Any other questions? Did I see Delegate Riley? And then I think I saw no one else, Delegate Riley.
Thank you, Madam Chair. Yeah, so in this situation, we're just talking about if the person called EMS or someone because of an overdose, not that there was a crime committed, right?
Correct.
Okay, so why would they need so it is kind of confusing why they would need to know if there was no crime, committed and they just, unfortunately, had an overdose, suicide, what have you. But do we know a reason of why they would want that at that?
So my understanding is at times when there are overdoses, EMS providers do come out, and then sometimes law enforcement or other investigators come out as well. And they can pursue investigations, but again, because of the way the law is written, is that it's explicitly said you're not supposed to use this information that's being provided for the purposes of
Right, this is definitely a health issue, not a crime.
Exactly.
So, okay, thank you very much. Appreciate it.
Thank you, Delegate Riley. Delegate Rosenberg.
Thank you, Madam Chair. Ms. Mayhew, perhaps you've answered this before, but have you spoken with the Commissioner of Police about the problem? One, and are you aware of whether or not this is a concern in other jurisdictions?
Yes, our law enforcement department, the Commissioner's office, they are aware of this issue, and it is broader than just police because it entails all investigators, so also prosecutors, anyone doing research on this that would be coming with a warrant or a subpoena. So we do believe that if this is a case where we're seeing some of this in Baltimore City, that we are concerned it could be happening elsewhere.
All right.
And that's just why we want to close the loophole.
All right. So this is what I'm going to propose that we do. Delegate Rosenberg, were you done? And I apologize.
I'm done. Sorry.
Okay. It's okay.
Yeah.
And before, I like to always allow you guys to ask your questions before I do. Anyone else? Okay, great. So this is what I'm going to propose that we do. Erin, can you ask the Attorney General's office to look at the original bill and to clarify in the letter that we do not, that this information is not to be given, and do they think that we should clarify it? And then if they give us that letter, then Ms. Mehu, I'd like you to take that letter to the police department and to the prosecutor's office and share the letter with them so that they know, and any practicing lawyers and EMS can have it. And when they are asked the question, they can dispatch the letter. Okay. If the Attorney General feels that we need clarification to make it stronger, we'll put the bill back in subcommittee. Is that okay?
Yes, thank you.
My pleasure. Erin, is that clear, or do you need anything else from me?
No, that's clear.
Okay, thank you so much. I appreciate it. And I'm going to hold it and wait to hear from the AG's office, okay? If they think it needs clarification, we're going to put the bill back in. Okay?
Sounds good. Thank you so much.
My pleasure. Thank you for caring and for your testimony always. Next, we have House Bill 906, Health Equity Resource Communities Modifications. Erin, I'd like you to please describe the bill, and then I know we have Mr. Mark Luckner who will speak on the bill, and anyone else that wants to be heard. Erin, thank you so much.
There's a reprint on the bill on pages 6 through 8 of your packet that reflects amendments requested by the sponsor of the bill at the bill hearing. The bill would alter provisions relating to health equity resource communities and it requires the Chesapeake Regional Information System for our patients, which is known as CRISP, to provide technical assistance to the Maryland Community Health Resources Commission in implementing health equity resource communities. The date by which the MHCRC must issue a report for request for proposals to designate health equity resource communities is delayed from October 1st, 2022 to October 1st, 2023. The bill also expands the purpose of the Health Equity Resource Community Reserve Fund to include in 2022 funding 2 full-time community health resource community staff positions, and in fiscal 2024 and in each fiscal year thereafter, the costs incurred by CRISP in providing technical assistance. There is also an additional amendment on page 7 that the fund can be used for the purpose of funding 1 full-time staff position under the pathways to community health resources communities. That's under 19.2.12 of the Health General article.
Thank you, Erin. Mark, tell us in very simple language why we need this bill.
Thank you, Madam Vice Chair. It's really great to see you again. And I would just say me too to your council's comments, but just why we need this bill, a couple of reasons. Number one, your full committee passed this landmark legislation last year that sets up two parts of the bill. Number one, the Pathways to Health Equity program, which is funded at $14 million a year. And as I said at the bill hearing, the commission's awarded 9 grants totaling $13.5 million. And those grants are to be for 2 years. So the first part of this bill, House Bill 906, allows those 9 grantees 12 additional months to implement their programs such that they can apply for the second part of the bill, the Health Equity Resource Community Fund. That's that RFP that Erin said will be released under the new bill, October 2023. The second part of this bill that you have before you, and thanks again to Delegate Lewis for introducing it, is to allow us to use the HERC fund, that's the second fund under the program, to have a second contract with CRISP. We have a current contract with CRISP to support the Pathways to Health Equity program, and we're delighted that Craig Bem, who I think is on the call here, is here to answering questions. But we want to use the second HERC fund to support a second cost of the contract with CRISP. And then the third and final thing that this bill does is it allows us to use the HERC fund, which takes effect this coming July. It's in the governor's fiscal 23 budget, to fund 3 new staff positions and that new contract with CRISP. And as I said earlier, we're currently recruiting for a Health Equity Resource Community Project Director. We're thrilled that we got 40 resumes, and those resumes are being reviewed by the Department's Office of Human Resources, and I anticipate interviews being set up in the next couple of weeks. So that, Madam Vice Chair, I'd be happy to answer any questions about House Bill 906 as amended.
One second. Thank you so much. Are there any questions for the committee? I'm sorry, from the committee to Mr. Luckner or to Erin or I? Craig, would you like to be heard? And thank you for always being there for us. I really appreciate your assistance.
No, glad to do. I will just say first, Mark and the commission is doing great work. The first round of Pathways applicants and awardees is going to be really powerful. And I wanted to assure the committee that CRISP is aware of this. We're ready. We see a lot of value in reusing the data and infrastructure for these purposes. And so glad to answer questions if there are any.
All right, any questions from anyone? All right, seeing none on the amendments, may I have a motion, please?
Move the amendments.
May I have a second? It's been moved in second. Any questions or concerns? Seeing none, all those in favor say aye. Any opposed? And the bill is amended. May I have a motion, please?
Move the bill as amended.
May I have a second? It's been moved in second. Any questions on the bill as amended? All those in favor say aye. Any opposition? Seeing none, the bill passes unanimous. Thank you so much for being with us today. We appreciate your work and everything you do. Next, we have House Bill 971, and then we have one more bill. All right, House Bill 971. Erin, will you be so kind and describe what the bill does?
This bill requires the Maryland Department of Health and the Behavioral Health Administration to ensure that the specialty mental health system has an adequate network of providers available to provide alcohol and drug abuse treatment for children younger than age 18.
Okay, and I know that I spoke to Delegate Kipke, and Delegate Kipke said that because the fiscal note is over $500,000, that the governor was going to put it in the supplemental. So what I want to do is discuss the bill, see if we can take a vote on it, and then we'll figure out, as we do with the other ones, the fiscal impact. Okay. Anyone wants to be heard on this bill? Ms. Gittes, did you want to be heard on this bill?
Yes, thank you, Madam
My
Chair.
pleasure.
I'm with the Maryland Coalition of Families. We provide family peer support to families caring for a child with mental health or substance use issues, and this bill is really needed. Currently, there is none adolescent residential substance use treatment programs in Maryland. At one time, there were 4. The last one closed down 3 years ago. They closed down for a variety of reasons. There were low rates. DJS wasn't sending kids there anymore. There are more complex kids that were needing one-on-one care, and the ASO was only approving a few days up to a week of treatment before the youth had to be discharged. So the programs were not financially viable, and they all shut down. So currently, kids with serious substance use issues who are assessed at needing ASM 3.5 or 3.7 level of care are they're pretty much out of luck. Some end up in DJS, some end up in psychiatric residential treatment centers, but those do not provide substance use treatment. A family can request from MDH that their child go out of state for the substance use treatment they need. That's very expensive. That's not optimal. And we're not hearing that those are really being approved. I know a few families that have been waiting for approval. So we really do need something in state, a continuum of care for these youth with very serious substance use issues.
Thank you. Thank you so much for your advocacy. We appreciate it. Are there any questions, anyone else that wants to be heard on this bill before I open it up for questions? All right, seeing none from the committee members, are there any questions on this bill? Okay, and everyone understands the fiscal note? Great. Seeing no questions, may I have, there were no amendments, correct?
Correct.
All right, may I have a motion on the bill, please? May I have a second?
Second.
It's been moved in second. Any questions on the bill as amended? I mean, on the bill that has no amendments, sorry, no amendments. All right, all those in favor say aye. Any opposition on this great bill? Seeing none, the bill passes, is unanimous. Thank you, Ms. Gittes. We really appreciate you. On behalf of Delegate Kipke, thank you for coming today, okay? Wonderful. The last bill of the day is House Bill 1080. And that is Maryland Medical Assistance Program, Children and Pregnant Women, Healthy Babies Equity Act. Aaron.
The bill requires Medicaid to provide comprehensive medical care and other healthcare services to non-citizen pregnant women who would be eligible for Medicaid but for their immigration status, and to their children up to the age of 1. The Maryland Department of Health must apply for a waiver from the Federal Centers for Medicare and Medicaid Services that maximizes federal funding and the individuals who would be eligible for Medicaid under the bill.
Dr. Polsky, tell us why we need this bill, and anyone else that is here to speak. Go ahead. Good afternoon.
Thank you, Madam Vice Chair. Most of what will be covered on this bill is already absorbed by Medicaid or by Maryland taxpayers, namely the labor and delivery costs, the hospitalization costs for pregnant women. And then for children of those women, they are covered up to 1 year of age, at least through an XO2 waiver through Medicaid. The big improvement with this bill is it would allow preventive care, prenatal care for these women, which, number one, as the Vice Chair mentioned during the original hearing, actually lowers the percentage of the costs absorbed by Maryland taxpayers from 50% of costs currently down to 35% of cost. And it also will reduce some other costs. It should decrease cesarean section rates, which add to the costs, and also should very much decrease the incidence of preterm births, which even one single 27, 28-week preterm birth can easily exceed $100,000 for one case. So from a fiscal standpoint, I would say the fiscal note overstates the cost. I think it's actually a lower cost to the taxpayers. It's even plausible that this could end up saving money for Maryland taxpayers. And certainly from a humanitarian aspect, providing very needed prenatal care and that important postpartum care for women who have postpartum depression, have preeclampsia, cardiomyopathy, other conditions that potentially can be life-threatening. This seems like a wonderful bill to move ahead to accomplish those goods. Thank you.
Thank you. And I was reading the fiscal note that while there's an expected 14.8 million increase in general fund expenditure, it will be offset by a reduced expenditure of $13.4 million due to a higher match of labor and delivery. So it makes sense. I was really pleased with the fiscal note. Are there any advocates that want to be heard on this bill? And Seacock?
Madam Chair, on behalf of Healthcare for the Homeless, we think this is a fabulous bill, and groups like Healthcare for the Homeless are only seeing more and more people in this kind of situation. They're actually to the point where they're going to need to figure out how to hire some prenatal and OBGYN kind of services for the number of clients they're seeing. So this would be a tremendous asset to the community.
And before I open it up to the committee members, 17 states are doing it, including Virginia already, because they are finding out that they're saving money and they're spending the money, more money as actually. Are there any questions from the committee members on House Bill 1080? Delegate Shalega.
Thanks, Madam Chair. And of course, everyone supports the humanitarian aspect of this bill. I don't think any of us don't care about pregnant women and newborns and new mamas. My question is, do you have any, are you putting any qualifier for the number of days, weeks, or months a woman would need to be in Maryland?
There's not a qualifier in here because they're getting their care. They're already here already. So I don't think that the bill has a requirement or that we have, Maryland residency. In Maryland, in order to have residency, I believe is 30 days. Am I correct?
I don't know. I don't know how you would determine that if they're not legal, how you determine that. So my question
you can determine that because they can get a driver's license in Maryland and they can get a non-driver's license identification in Maryland.
That's pretty hard to do. There's a limited number of those slots available every month, but I'm sure, you would use some other documentation. My concern is this, this could draw women to Maryland who know that they're going to get free care. And we know the southern borders are open. And there are a lot of people coming here for, all the obvious reasons. It's opportunities and jobs. But we have a responsibility to Maryland taxpayers to make sure that we're not becoming a destination or a beacon for illegal immigrants to come here to have babies. And I care about these women, I care about their babies, but it would be safer and better for them to stay at home and not travel while they're pregnant. And so there are those health risks on that side. And then the other side of the coin are taxpayers who you are now putting a burden on, who are paying for something for gas, and we're raising their taxes. And You know, I have serious concerns if you're not going to put any limits on, I know the desire is to take care of women who are here, but I think you're creating a destination for that.
And Delegate, I do, go ahead, Dr. Polsky, and then I'll address the delegate. Go ahead.
I was going to say, as the chair mentioned, a third of the states already have similar legislation in effect, including Virginia. And I've not heard anything from my colleagues, my OB colleagues in Virginia, that there's been an issue with women coming across the border from Maryland to get care in their state. So although hypothetically, I think that potential exists, we just don't see it, not only in this regard, but in other regards when state by state, there are changes in Medicaid.
And not only that, if I may add, and you took the words out of my mouth, you know, 17 other states do it. There's no reason why they will come here. Virginia does it. And if a woman is here one day and she ends up, you know, let's say she's driving through Maryland and going to Virginia, and she ends up basically in the ER giving birth, emergency Medicaid under the federal government allows Maryland, you know, to apply for emergency Medicaid. So she will get paid, you know, Maryland will get paid anyway, which is why I believe the other states do not have, you know, the residency requirement. You know, the expansion here actually saves money for the taxpayers. It really does. And it makes sense. And again, a third of the states are doing it already. I have Delegate Chisholm followed by Delegate Kaiser.
Thank you, Madam Chair. And I echo Delegate Schlager's concerns. I mean, we all care about these mothers and especially the infants as well. But I do have a technical question. So I'm looking at the fiscal note, and it says Medicaid covers pregnant women with incomes up to 138% of the federal poverty level. How do we make that calculation if they're here and they're undocumented and we don't have a tax return, they haven't filed a tax return? Are we just going to take everybody at face value that they're in this? Because, look, we all know, I know several people who might be here undocumented that make a lot of money, especially in today's free market world where we have a labor shortage, and oftentimes you'll find people that are here making a very strong living, but then we're going to be dumping people into Medicaid that maybe otherwise could afford it. And I know your hope is to get them onto an exchange someday, but I don't understand how you do the calculation for the Medicaid if we don't really have any documentation or income documents on these people we're looking to cover in this bill.
Like in Virginia, the eligibility criteria is that someone that lives in Virginia. Basically, other states have done that, so there must be a process in place that the hospitals do, and the application. I never fill out an application like that, thank God, but there must be a process in place because other states are doing it. Dr. Polsky, would you like to be heard on that?
And I'm not sure how the eligibility determinations are made, so I unfortunately can't offer any additional information.
Yeah.
Is it a federal? Well, I'm wondering, is it a federal calculation or a federal? I guess
it is a federal law because we're asking for a waiver, so it is a federal law.
Okay, thank you.
Yeah,
Thank
it's
you,
a
Madam Chair.
federal law. My pleasure. It's a federal law, and basically the state's request, what we're doing in this bill is allowing Maryland to seek that waiver so they can take advantage of that federal law that gives money to the states to service that population. So the federal law has their own criteria and processes which they have. And basically the criteria for the state is that the person be someone that lives in that state as well.
I'm just curious, we still would need to know, how do you confirm that eligibility? You have to be eligible for Medicaid. Who is doing that confirmation without any documents?
Well, I know that my office helped someone get emergency Medicaid, and I dealt with Webster Yee from the department, and the person applied, and the application asked them for their address, right? and ask them more information on their background. So they do have things in place on how they ascertain that this person lives here.
Okay, thank you, Madam Chair.
My pleasure. We have Delegate Kaiser and then Delegate Robin Lewis.
Thank you, Madam Chair. I heard the concern about making our state a destination location, which is the same thing I think you and I both heard in 2011 for the in-state tuition bill. I'm building up to isn't that so kind of question, but there was no evidence at the time that any state, including even, especially since other states like Texas provided that same benefit, that people weren't going to come all the way up to Maryland for something like that. So I just think those concerns are unfounded, or that the evidence suggests that they just don't happen. So isn't that so?
Thank you. Delegate Lewis.
May I try to answer the question about eligibility determination for a Medicaid?
Absolutely. You actually used to work for the Maryland Health Exchange. Go ahead. I love my committee. Everyone here, every single one of you has great experience and background that is so, useful. So I appreciate it.
It's a great example of how the sum is greater than the whole is greater than the sum of the parts. Together, we're like one gigantic brain. We can answer every question. But I also learned a lot about Medicaid eligibility determinations a few years ago when I worked on the financial assistance legislation. And so that was a bill that we passed that became law that requires hospitals to take extra care in determining whether patients coming in through the emergency room or through admission are actually too poor or uninsured and could be eligible for financial assistance, which is a program that we, the legislature, make possible. It's charity care, free care, whatever we call it. It already exists, and the taxpayers are already funding charity care statewide. So the way my understanding, when a person comes through the emergency room or is admitted in some fashion for inpatient care, their eligibility for, first of all, there's a question. The first question is, do you have insurance or don't? Yes, no. If you don't have insurance, there's an algorithm or decision tree that's followed by the hospital ER staff or admission staff. This is every hospital in the state. Clear procedure, because hospitals are not interested in taking care of people for free. So at every entry point into our healthcare system, there's an eligibility determination. Are you covered or not covered? If you're covered, great. They get your health insurance coverage information. If you're not covered, there's another decision tree. If you're not covered, are you eligible for Medicaid? And every intake point in our healthcare system has an algorithm to answer that question. One of the things the financial assistance bill did was it expanded the kind of documentation that can be used to determine income, which is a key factor for Medicaid eligibility. And one of the things that we passed in that financial assistance bill was to make it easier to determine income by showing a tax return, if you have one, by sharing a pay stub, if you have one, whether you are eligible for other types of public assistance, be it food stamps, whether your children are on CHIP already, and there are a few other factors. If you have housing assistance of some kind, et cetera, et cetera. So if you're already in the framework of our social safety net, which we all cherish and support, because there, but for the grace of God, go you or I. If you're already in the social safety net, in a social safety net program, your eligibility is assumed and then is verified over as required. So no one is crossing the border willy-nilly because Maryland is this magical destination. People are living their lives day to day, trying to make it just like we are. And they may find themselves in need of emergency medical care, and they may indeed qualify for Medicaid. And I hope that answers, brings us further along to understanding that question. Thank you, Madam Chair.
Thank you. Any other questions or concerns? All right, does anyone else want to be heard? Delegate Hill.
Yeah, I just wanted to add to Delegate Lewis's excellent explanation that I know that at the hospitals, certainly when I was in residency, and that was in New York, where this was, was much more common for people. We knew people were coming in using other people's ID. We never asked. We take care of people, and the same thing holds true today. People are being taken care of, but there's no reimbursement. And then what's happening is they're not getting the proper care because they're not able to qualify for non-emergency care, the prenatal care, the early postnatal care, or the care for a year. So what happens is they show up in the emergency room, they show up with major issues, and we will be paying for that as we have been. So if we can get them the proper care, they can have healthier babies and healthier outcomes. And we pay less in the long run. And it's the right thing to do.
Okay, thank you. Any other questions or concerns? Seeing none, Erin, there are no amendments here, right? Okay, on the bill, may I have a motion, please?
Move the bill.
May I have a second?
Second.
Any questions or concern on the bill? Delegate Hill, your hand is up. Is that from the last? Yes. All right. All those in favor say aye.
Aye.
Okay. Any opposition? Will you please raise the little hand, please? I have Delegate Shalega, Delegate Riley, Delegate Chisholm. All right. Thank you so much, everyone, for coming today. I really appreciate the conversation. Regardless of where we all are, it's very decent and respectful, and I'm very grateful. I don't expect anything less from this committee, which is, I think, the best committee in the House. So anyway, that being said, we do have hearings at 2 o'clock. Sorry, we had 10 bills today, and I hope you get to drink something and eat something quickly. Thank you, Erin, for everything. You have a blessed afternoon. See you shortly. Thank you so much. Thank you, Edith, for staffing.